I'm your host, your moderator, Dr. Lorne Brown. I'm a practitioner of Chinese medicine. My practice is called AcuBalance and is located in Vancouver, British Columbia, Canada. Today we have our three presenters, experts in the field of Chinese medicine and acupuncture, in particular in treating women throughout their pregnancy. Claudia Sikovitz from New York, Deborah Betts from New Zealand, and Sarah Budd from Devon, UK, United Kingdom. You see the bottom right there, the disclaimer. I just want to remind you, this is for educational purposes only. This is not meant to replace getting medical advice or treatment. If you have a medical condition, especially related to the topic of acupuncture, or related to the topic to birth and pregnancy, do seek out a healthcare provider. This is meant for educational purposes. And this talk kind of came about because of what we were seeing in one of the Facebook groups on Acupuncturists for Facebook, a lot of questions about inductions. And this is what kind of prompted the discussion between Claudia, Deborah, and Sarah to kind of have this discussion with the group with our goal is to make sure we, do no harm and also offer effective and safe treatments to the public. Just a little introduction to our speakers. I'll just give you my personal experience because I've had experience with all three. Closest to me here is Claudia Sikovitz, located in New York. Claudia is involved in training and teaching in the hospital setting, so offering acupuncture courses inside hospital setting with women in their late stages and throughout labor, and involved hopefully soon with even more research. So do Google or check out Claudia Sikovitz because she has a hands-on training which is excellent, and often is our moderator for our Acupuncture Journal Club. Deborah Betts has a published textbook on using acupuncture in pregnancy and labor out of New Zealand. Her background is a nurse, then acupuncture, and she's been involved in lots of research. She also has several lectures, of course, as well, which I believe we call the A to Z of treating women throughout pregnancy using acupuncture. Sarah Budd out of the UK is first trained as a midwife and also as an acupuncturist. She's been involved in research in using acupuncture to treat women throughout her pregnancy. Also lectures internationally on red flags that acupuncturists need to know about when treating women in their pregnancy. So I would like to lead off with why we started today, and I'm just going to put the first question out here. There was a lot of chatter on Facebook about treating women in pregnancy, in particular around birth or to get labor going. And I'm just going to quote here. It says, the question for the panel here, is a Facebook group appropriate for asking for points to use in treatment, such as, and we're going to quote, this is from a Facebook post, and there's multiple of these. I have a patient who called to book an appointment wanting to start her labor who is at 39 weeks. Any tips on points and intensity? So I'd like to just open this up to Claudia first. Are there any concerns around Facebook and this type of questioning that we're seeing on Facebook?
Oh my goodness, yes. I mean, sort of like, where do you start? I don't want to use them all up, how many questions and problems I have about this kind of questioning. It implies that getting a labor going is so easy that you could just take a couple of tips from a stranger on Facebook, and that would be just fine. And then the another big problem I have with it is the idea that we might think that communications on Facebook are in any way private. Several times people will get in a snit about this is a closed group and there aren't supposed to be XYZ in the closed group, but there are. There are always people, even if you think it's a closed group, who, if it's large enough, you didn't expect to be there. So it's slightly less public than writing it on the bathroom wall, but not by much, in my opinion.
Okay. Anything to add to this, Deborah or Sarah? Deborah first.
Really, just the idea is, as a profession, it does raise alarm bells for me, as Claudia outlined. And I think, Lorne, I just think we have professional, as we become more mainstream and more accepted in society, there's going to be a kickback. We can already see Friends from Science, the skeptic clubs, and one of the things that they look at doing is looking at people's websites, and it's not beyond belief that they would join Facebook groups to actually mine there for information that will make us look less credible. And when I read some of the postings, I am concerned about us as a professional group. I think, Lorne, you brought up quite clearly that you can never take something off Facebook, and that the joining criteria may not be very strict for some of these closed groups. And that if a lawyer went on there and found that the only information you got was a tip from somebody that you didn't know, that doesn't put us in the same profession as we'd like to be, really, as a dentist or or another medical professional. So.
Yeah, and I'll just add to that, the discussion we had, I think, the last time and even before we started our webinar today is it just could lead to, it could allow for legal action. If you basically are on the Facebook and you post, I have a patient like this case who's 39 weeks, what points, and you take these points and use them, you're basically showing negligence. You're showing you didn't know how to treat the person, and you've accepted the information from a stranger, because you really don't know if that person truly is an LAC or what their experience is. And the point we've had this discussion is in our profession there seems to be a lot of questioning about medical doctors and physios doing acupuncture not having enough hours of training. And so if you can go onto Facebook and ask a question with very little detail, and all you need is to get a cookbook of points back, then really, why are we going to school for so many hours, and why are we critical of other professions doing only a couple hundred hours of acupuncture if somebody can go in and make a post like this and then take this back and treat somebody? So I just think legally it would demonstrate possibly, I'm not a lawyer, but it could show that you were negligent because you got advice from a stranger, and because you're asking this question, you're showing you don't know how to treat it. So that was the issue I had with Facebook, is lawyers will eventually start to come to these groups, and it's documented that you were negligent and that you took advice from a stranger. And Sarah, anything to add to that?
Well, just following on from it, really, the same sort of thoughts that, who's looking at these pages, and what does it make us look like as a profession when people are demonstrating that they don't really know enough about the subject, which brings into question what level of undergraduate training are they getting in areas like obstetrics. Maybe we need to look at that, because if they are getting adequate training, then they really shouldn't be needing to asking some of these questions that are in this Facebook feed I find quite alarming. So I think we need to look at why people are needing to put these posts there in the first place. Is that because the undergraduate training isn't covering the subject well enough, or postgrad CPD training, people not taking up the opportunities, because there are lots of opportunities out there, as we know, Claudia and we all run CPD courses. There are plenty of them around, and of course you have all of yours that you're providing, Lorne. So I think we need to look at why these people are actually having to do this in the first place.
Thank you. And medical colleagues definitely discuss cases, so it's not that you can't talk to a colleague. I belong to some real private groups, they're not on Facebooks, and you can't be in this group unless you are a true member, meaning you've gone through, you've written an exam and you pay your dues and you're part of this group. I'm speaking, in my opinion, the American Board of Oriental Reproductive Medicine, FABORM, we have a chat group. And so I actually know these individuals. And so when I'm asking questions and we're sharing cases and discussions, at least I know that the person that is responding has experience. They're not a stranger to me. So you can still ask questions, and medical professionals constantly do that. I think on Facebook what we're seeing and what Sarah was alluding to is they're kind of like this one. They're open-ended. There's really not a lot of history given here. And the idea that, again, all other speakers have brought up, that it's that simple, that all you need to do is put in a few points for somebody who's trying to get them into to labor. It's not that simple. And so that's the issue. It's more with Facebook. I know you can Skype with colleagues, you can email with colleagues, and you can discuss cases, but Facebook doesn't seem to be the appropriate place to be getting your clinical treatment plans from. Is that kind of what we're agreeing on? And it's not good for the profession's credibility. It's not good for your own legal and insurance-wise. It's putting yourself at risk. And so as a profession, maybe Facebook is not the place to seek advice for treating patients. Is that...
No, and I think there are plenty of other outlets. You know, there are, in the UK, there are Acupuncture for Childbirth team groups. I'm sure there's lots of other groups in other countries. There's supervisory groups, regional groups where people can discuss these things, as you say, but I just don't feel that Facebook is the right arena.
Great. All right, well, let's go to another question then. So thank you guys all for that. Nobody has added any comments. And Emily says, not to mention, why does the patient ever need to be induced? Oh, Emily, we're going to get to all that. All right, so here we go. Let's get into the clinical side of it, what people are interested in. And again, this is for educational purposes only. Remember, everybody. What is the difference between cervical ripening and induction? Because I know, Deborah, on your website, in some of your teachings, you just use the term cervical ripening. And then later on, it's a two-part question. Induction versus labor preparation. What terminology do you recommend we use as a licensed acupuncturist? So who wants to start first on this one? Or would you prefer I choose?
You should know us better than that, Lorne.
Deborah, go for it.
I don't mind starting with the cervical ripening just because this is something that the midwives taught me really, is that you want the cervix to be thinned out and dilated before the woman even has a contraction. And so cervical ripening is a process where you're assisting the woman's body to work really well so that when she does go into labour, the labour goes efficiently. And it's about having, for me, it's about the rationale, and labour preparation is a much better term because labour induction is completely different to me. It's when you want that woman to be induced, and it's very similar to a medical induction idea. You're forcing something to happen. Whereas labour preparation, which involves things like putting the baby in trying to get the baby to move into the best possible position, helping the woman's body's hormone stimulation response so that her cervix starts to ripen and become effaced, dealing with emotional issues to help oxytocin levels, dealing with pain that she might be having so that she can sleep well. All of those things become labour preparation, and to me they're just very, very different from labour induction. And to me, induction is quite a violent procedure where you're forcing the body to do something it doesn't want to do. And sometimes there are good reasons for that, but if people take away anything from me, I would like them to think that they need to have a rationale when they put a needle into somebody, and that if your rationale is to help a Western medicine induction because the woman is going to be medically induced, then that's a good rationale. But just the woman saying, I want to have this baby, I'm 39 weeks, is not an acupuncture rationale for your treatment.
Thank you.
Right.
Sarah.
I'll hand over to the other for the words of wisdom.
Sarah, but
I've got some.
Yeah, well, that's beautifully put by Deborah, as always. Yes, I mean, we're talking about the process of effacement, and I don't know about in your own countries, but certainly in the UK, the normal way of trying to stimulate labour, first of all, is that the midwife will try and get this cervical ripening process started by doing something called a membrane sweep, where she'll do a vaginal examination and sweep her fingers over the membranes around the baby's head to stimulate hormones. This isn't an induction, it's more like a preparation for labour. I think the word induction can really be considered as an obstetric intervention. That's what it originates as. And so I think as acupuncturists we have to be very careful about the terminology we use. And again, I know it's different because we're all in different countries, but in terms of insurance and what you're covered for, I think you need to be extremely careful using a word like induction. So to me, cervical ripening and getting ready for labour is a much more gentle process. as Deborah said, it's not just about needles to cause contractions. It's about how the woman is emotionally, the position of the baby, and all of those things. When we get down to the more invasive, if you like, word induction, this is really medically when there's no going back. You know, once you've induced a labour, you're talking about the membranes being ruptured and a drip being put up. So I guess the acupuncture equivalent to that would be putting needles in all the points that you can possibly think of to stimulate contractions, and that's not really what we're about. I hope. So that's, to me, you know, I'll separate, you know, the woman's position in this and how much pressure they put on us. That's a separate discussion, which I'm sure we'll come to in a minute. But I think in terms of terminology, it's important to be clear about this word induction. Okay.
Good point. Claudia Sikovitz. So what is the difference between cervical ripening and induction? If you can add to what Sarah and Deborah have discussed, and as Emily put it, and I added, not to mention, why does the patient even need to be induced? Do you have any concerns around this? Any thoughts?
All of these questions are particularly important for the American audience because lawsuits are so much higher here, and because the majority of acupuncturists in the U.S. Insure with American Acupuncture Council, and when they have that question on your application that says, do you practice obstetrics? If you offer services of cervical ripening and induction, they're in a very good position to say that they don't need to cover you if that patient should happen to sue, because that was the practice of obstetrics. And people who have checked those boxes have emailed me in distress because the company then wants to charge them $15,000 for their coverage. So even on a very practical level, in the U.S. and over and above the complete agreement with Deborah and Sarah about the clinical business of these terms, it's really important to avoid Western medical technical terms in speaking to our patients about what we do, which is to help their body be the best prepared and do the best job of having a wonderful labor that they can. And even if they are headed towards an induction, what's a Western medical induction? What's the best possible way we can help them prepare for it is by helping them to ripen their cervix, to soften, we might say, to soften their liver channel, right? To have their body be more up and running. And it's not, we don't have demonstrable effects that are measured with Western endpoints, like how effaced is the cervix, how dilated it is, how soft is it, has it moved from back to front. These are all important parameters of what's going on in the patient's body, but our job is to help the patient's body do that the best. Making contractions occasionally, lack of contractions is the only reason the person isn't in labor. If they're very young, deficient, or damp, they might have effaced nicely, but they haven't just gotten around to their contractions, and in that person, just starting contractions might be the right way forward for them. But as Emily points out, really we're helping their body to figure out what's needed next, and that's a personal consultation.
And so what about terminology then? Because you talked about the logistics, induction, and so, and I've heard intention, like what are you doing here? Are you trying to force this baby out, or are you trying to support this woman's process? So can you help us with some of the terminology that we could be using in our discussion with patients, other medical professionals, and our literature? Can you go over that? And the question here is induction versus labor preparation, or pre-birth, or cervical ripening. Can you give us some terminology that we can use as licensed acupuncturists? And, Sarah, you can go first for this one. You haven't had to go first yet. So.
Okay. Well, yes, I think we have to be very careful with the terminology, and I think we need to also look at what our role is. There is tremendous pressure from a lot of women at the end of pregnancy, understandably, because they've had enough and they really want the baby out. So I think we need to look at what is happening to them on the other side in terms of the medical process. If the woman is being given a date to be admitted to hospital to have a conventional induction of labour, then I think there's a discussion to be had whether we can do something that will help her try and avoid having a medical intervention. But I think, again, we need to be very careful in terms of how far we go with that. And I think it's good to open up dialogue with her midwife or obstetric caregivers if we are thinking of using a much more powerful technique. I don't want to call it induction. I would discuss it with the woman as trying to support her body in getting closer to labour, and that the acupuncture can be used to get her in the best possible condition, and that if the baby's nearly ready and that her body's nearly ready, that we're just helping that process along. I wouldn't use the word induction at all.
Deborah, so I'm going to try and pull out more of this terminology, how cervical ripening, labor preparation, pre-birth. So, Deborah, the scenario is a woman comes to your practice, she's pregnant, she's 34 weeks, baby's head down, she's nervous about having to have a C-section if she goes past her due date. What's the conversation you have with her, and are you recommending the weekly treatment starting around week 37? Can you walk us through kind of a conversation that you would educate this patient that's worried about being induced or having a C-section? It's her first baby. She's 34 weeks. Some good friend had bought her a gift certificate to come see you for acupuncture in her pregnancy at 34 weeks. I'd love to hear kind of how you would work through this.
Yeah, okay, Lorne, we see a lot of this because I work in a hospital clinic where people do book in. They book in at 36 weeks or 37 weeks for a once-a-weekly treatment. So what I'd be saying to this woman, well, look, there are things that you can do to prepare your body to have the most efficient labour possible. And one of those things is to come in and have the acupuncture treatment. We will also be giving you homework. So to me, that's using a lot of discussions around what are they most scared of, how are they going to deal with that, what conversations are they having with their midwife about putting in place an effective plan. And there's also a lot of websites I give people to go to about babies' positions, about big babies, answering questions about why it's useful to go to 41 weeks. So there's a lot of information there that you can tailor to that particular woman. To me, it's a question of bringing them back at 36 weeks or 37 weeks, and when you see something in the conversation, dealing with it. So part of preparation to me is a big aspect of, if they're not sleeping well, you need to focus on that. If they've got pain, back pain, hip pain that's causing them to wake up, that needs to be dealt with. If they've got hemorrhoids or vulval varices, then how are they going to feel about pushing a baby out? So it's that whole idea of dealing with the problems that they've got and ensuring that there's not triggers there that they're sitting on and stewing on emotional factors that are going to make the labour not effective once it starts. So my advice really is that there are things that we can do. I call it pre-birth, that there's a pre-birth treatment that's a labour preparation treatment that's designed to get their body into a good place. It's not designed to start contractions. And that the time that we would talk about that is the scenario if they are going to be booked in for a medical induction, because sometimes there are good reasons why women need to have their babies within a certain time frame, that they can come back and we will discuss the treatment designed around that. One of the things that I make very clear to women who are asking to have any day now, I'd really like to have this, I've got a holiday planned in 2 weeks, or my husband has to go back to work, or my mother-in-law's coming to visit and she can only come at this time, is that I discuss with the woman that we don't really know what starts labour, but part of it is linked to the brain development of the baby, they now think. So it's at the optimum time for the baby's brain development. And part of it is linked to the baby being able to clear amniotic fluid out of its lungs. So it starts reducing the amount of amniotic fluid in its lungs 3 to 4 days before a natural delivery. So although the woman might think that 39 weeks or 40 weeks is the ideal time to have a baby, that baby might be planning on a week later. And I also bring in, because of my background now in doing some research and being able to read research, I also make it very clear that the research shows that when you just try to induce contractions, there are no better outcomes for women. You can get contractions started, but the labours are just the same as if they're medically induced. So to me, there's no better outcomes for less pain relief, less epidurals, less cesareans. So I try to be very clear to women that just because you get labour started, it doesn't actually mean they're going to have a nicer labour. And to me, that idea of why would we want to use the word induction when women are trying to avoid a medical induction? Because what we're doing is exactly the same. We're pushing her body to do something that it's actually not ready to do just yet. So that's a long thing in there, but those are the types of conversations I have with women, because it's no good if they turn up and they're desperate to have their baby on Tuesday because it fits in with their social, what's happening with them. It's no good just saying, no, I'm not going to induce you. If they're asking for an induction, they actually have to buy into why it's better to wait and why it's better just to prepare their bodies. And once I've had those conversations with women, I've never had anyone turn around and say, no, please just induce me. I don't care about a nicer labour at the end of it. I just want to get things started tonight. So I think it's our responsibility as practitioners. We're making the decisions about what to treat, and we have to spend time educating patients about why we have a rationale for what we're doing. I say quite clear, I have said clearly to people, I'm not prepared to push things and do a really strong treatment design to get contractions started, because if something happened and their baby ended up in neonates and then didn't breastfeed well and had problems, that I would feel responsible for rushing things. So I have said that to women, that it's a problem for me as well, because of my experience has been that just rushing into things doesn't actually result in a better labour. And that changed my whole mind, and I challenge anybody listening to this seminar who does a lot of inductions, acupuncture inductions, is to follow up your woman and actually find out what their birth experience was like, because that's what changed my mind. I had all these women ringing me afterwards saying I was cancelling appointments because they were going into labour, and when I rang them up, or when I was thanking me and saying thank you, I went and I started having contractions that night or the next day, and I went into hospital, and I was feeling really wonderful. It's nice when things work, and I was saying that acupuncture really worked. But when I said, great, how did the birth go? Their stories were not good. They weren't what I would have wanted. They stopped and they started, and then they needed a little bit of, a medical intervention, or they're tired and exhausted, or there was a hospital, and I was feeling really wonderful. It's nice when things work, and I was saying that acupuncture really worked. But when I said, great, how did the birth go? Their stories were not good. They weren't what I would have wanted. They stopped and they started, and then they needed a little bit of, a medical intervention, or they're tired and exhausted, or there were just things that were happening. They weren't having these nice, efficient, natural labours that I would have wanted. So I changed my mind about the idea of trying to get things started. Anyway, so those are the kind of conversations I have, Lorne, if that's helpful.
Okay. So Claudia, we're going to go to you before you jump in. If you have anything to add, and then also we're getting some questions, so we can start to use certain scenarios, because I think this is really helpful for the profession when they see it in real clinical situations, like the one we have up in the interview in the question period. So Claudia, we were talking about terminology you use and a scenario. If a woman comes in, how do you educate them? So you're using terminology and education to explain what you're going to do. Do you have anything to add, or should we go into maybe the specific question we have there about this 43-year-old patient?
Okay, I want to be really brief, but I'm very comfortable with labor preparation as a term, and I recommend it highly. It leads you to be able to have the conversation
I think Claudia's
with
on the internet
women
again.
saying,
We
unpacking the Western terminology, right? From a Western point of view, there's cervical ripening and there's contractions. Those are the two pieces of the labor. From a Chinese point of view, we have yin, which governs the ripening and the softening and the talking through everything they really need. And then just like the egg is huge and the sperm is but little, you just need a little bit of contraction to get the thing going, and that it's a better labor anyway if what we've worked on is the yin side of it. It's the easiest, it's the most important.
I think it's good now, but we didn't catch your response. So can you do it again? Because you seem to be back now, and you froze as soon as you started speaking. So can you repeat?
Hello. Yeah, it was just weird for a few minutes. I'm hoping it's going to straighten itself out. I have a backup. If I disappear for some reason, I'll log in on another computer. Okay. Sure, I will, but if I freeze again, just move on, because it's brief. I'm very comfortable with labor preparation, and I think it's a really good way to go because it sets you up to talk about the Western parameters of being ready for labor, which is having your cervix ripe and having contractions, and how those relate to our yin and yang. It's not like we don't know about them. It's not like we don't do them well. It's just that we do Chinese medicine.
She got help getting pregnant and fertility acupuncture, it sounds like, and now she's getting ready for delivery. She's currently 37 weeks, and her OB, her medical doctor, is requiring her to deliver before 40 weeks due to recent research that shows that women over 40 years have an increased rate of stillbirth if they deliver after 40 weeks. They call it here in B.C. 40 at 40 or something, I think. Emily, you can correct me what we call it here. We have this policy as well. She managed to push them to 39.5 weeks. So how do you use your acupuncture for this specific scenario? Deborah?
It's the same scenario with anything, whether it's gestational diabetes or a woman who's had a previous stillbirth and has been offered an induction at 38 weeks this time. There's just two areas. Labor preparation is when you're preparing the body, and then 2 or 3 days before a medical induction, because the medical caregivers do have the chief responsibility for the pregnancy. That you can actually start to use your acupressure or to actually design a treatment that's designed to help their medical induction work more effectively. If the woman happens to go into labour before the medical induction, then that's fine, but I'm always very careful to explain to women, we want that medical induction, which has been done for a very good reason, we want it to work so effectively that it's very straightforward, that there are no problems, and that she has a very efficient labour. Does that make sense? So it doesn't matter about the timing. It's just the idea of you're working with the Western medicine team to deliver the best outcomes for that woman and baby.
So I just I'm going to repeat kind of what I think I'm hearing, is that you're not promising that you're going to induce her and beat the medical induction. You're going to support her body so she either goes into labor because her body's ready before that medical induction, and if she does, the medical induction is more efficient and a more positive experience.
That's definitely the feedback I had from the midwives, is that that by preparing and supporting and using a rationale to get her body into the best possible place, that even if they need to start the medical induction, they're so pleasantly surprised about how well it goes. And it's good. If they think their induction worked fantastic, I'm happy with that. The woman has a straightforward labour, there's no complications, they need to use very little intervention, and that's a win-win situation for me, rather than trying to push things too fast. I don't really see the point of trying to induce her at 39 weeks. This woman here. So for this woman here, with the idea that she's going to be induced at 40, there's no point trying to get a strong induction acupuncture treatment going at 39. Just prepare, and then 3 to 4 days before her induction date, start to step up according to what's happening in her body, to make that induction the most successful.
Great. And her response in the chat room is, thank you, that's really good to hear. I hope this is her outcome. And then just kind of a follow-up question on that scenario is, regarding this question about inducing women over 40 weeks before 40, there's currently a trial in the northeast of England where all women over 37 are being offered an induction at 38 weeks. As some evidence has shown, there are more complications, neonatal ones, I think. These women are allowed to go 40 weeks. So again, for the scope of this talk, I think what Deborah has just shared is that we just offer our pre-birth stuff, so if they have the medical induction at 38 weeks, it's more positive, more efficient. We don't try and beat the medical induction. We don't try to be an acupuncture induction.
Oh, precisely. Yeah, at my institution, a lot of patients are induced at 38 weeks because they've got gestational diabetes. So their bodies haven't planned to go into labor at that time. They're not ready. And yet, just doing the labor prep is absolutely the best we can do for them. There's no percentage in chasing contractions. It's all about, as Deborah says, making it a better, easier, smoother induction. We should get people away from this idea of induction as a binary, induction bad, natural good, right? It's not like that.
Thank you. Here's a question about how do you educate the Western medical doctors and doulas who heap that acupunctural cervical ripening, or they group them all together. Acupunctural cervical ripening is with all medical interventions like membrane sweeps, causing a cascade of other interventions without having to teach them individually about differentiation and TCM theory. I'm going to rephrase this. So the question is, what about those that see acupuncture cervical ripening just like the medical inductions that have all these risks and side effects? How do you educate these health professionals so they'll refer the pregnant women to you to help do the birth preparation without having to give them a 3-year course?
We'll start by not calling it cervical ripening, right? Call it patient relaxation and labor preparation. That emphasize the relaxing the patient's pelvic floor, relaxing the patient's head, relaxing the patient's body, right? All birth professionals understand the value of relaxation. And then just point them to the research that says that in addition, cervical ripening and duration of labor do improve, but that it's not, there seems to be a very safe treatment.
Okay, so and I use the term Western medical docs, but it was midwives and doulas. But again, using the language and sharing with them what you're.
Yeah, and I think I totally agree with Claudia, and also just to add in that the research supports that the outcomes are beneficial, and there is no evidence of increased risk to the baby or to the mother. So that you need to be able to understand that and use that research. And I would also, what happened for me was being able to use acupressure. So to run acupressure workshops with midwives meant that you gave them some tools so that they actually felt more confident about what was happening and how it was stimulating beneficial responses in a woman's body, rather than an intervention that was forcing things to happen when the body wasn't ready for it.
I think I think we need to actually remember what happens to these women. Sarah. I mean, and I ask all the people listening to this, how does it feel when somebody says to you, we need to start your labor? Because I'm sorry, I've missed some of the conversation, but how does it feel right now if I said to you, you've got to have your labour induced because there's a risk to your baby of stillbirth and problems. Just think of the reaction that you're having in your body when you hear those words. You know, these women, their control is taken away, or their hopes for a natural childbirth, and in comes the big one, which is fear. You know, so I think we need to get back to actually looking at getting away from the medical terminology a little bit and thinking, what can we do? We have fantastic tools to help these women, you know, emotionally in this situation, because they're just going to get blocked with all this fear around and the sort of emotional blackmail that can be put their way by being told that they must do this, otherwise they're putting their baby's life at risk. So I think we need to get that side of things in perspective again.
Thank you. Thank you for that point. And it goes both ways. Sometimes it is necessary to save the baby, and sometimes it's because the attending physician has a golf game. So sometimes the patient has to advocate for themselves, and sometimes I'm sure these interventions are necessary, right? They save lives. They save babies that didn't survive 50 years ago.
And can I just jump in here,
And
Lorne?
our role, again, is, since we're not birth attendants, as far as I'm aware, licensed acupuncturists, we're there to support.
Sorry, I just wanted to jump in that for us to make sure we're careful about our scope of practice as well, in that we do not pressure the woman to make decisions as well, or weigh in, I don't think you should be, you know, they should be telling you this or that, because unless you are actually at that consult, you don't know what the woman's heard. So she might have heard her doctor say, we need to induce you, and thought it was for a different reason, but actually there is a problem in that pregnancy. And so it's not really, I think sometimes people feel, well, this shouldn't be happening, they shouldn't be inducing. We've got to empower those women to have confidence as well in their medical caregivers, and not to try and come in with another opinion to undermine their medical caregivers. But what I do think we can do is give women information, so they go back to their medical caregivers and they say, I don't understand why you're saying I need to be induced on Tuesday. And they just keep saying that until they explain to them why they're doing it. And my experience would be, if it's the golf game, they'll back off and they'll say, oh, okay, then we'll give you another few days. If it's because there's a real problem, and I suppose because I come from a neonatal nursing background, you know, there are problems, as Claudia, you know, is well aware of, and Sarah, they will say, no, you need to do this on Tuesday because of this and this reason. So I think that's an important part. It's not an us against them scenario. It's about working together as a team for the best outcomes for the woman.
Great, thank you. I'm going to put in another question here about, because we're talking about empowering women, and it ties into, again, I have to share my conflict of interest here, as I do sell continuing education courses on pregnancy. And so this question reminds me of Claudia Sikovitz's course that we have online at ProD, and it's basically a birth basics course. She's going to discuss acupressure, acupuncture, and Chinese medical diagnosis and birth. So there's my plug for Claudia's course. And the question is, what is the panel's opinion on offering pre-birth acupressure, so this is acupressure points, for the client and support people to use at home? Given the importance of knowing and understanding the specifics of her condition, do we have the same concerns arise as when using acupuncture? So is there any concerns here if you're sending them home with acupressure? And I'll plug Deborah Betts has her textbook, but she created this great PDF document that I know we give out to all of our patients once they're in that third trimester, on things that they and their support person can do using acupressure leading up to labor and during labor. So does anybody have any concerns about offering education and information for the support people to do acupressure on the
Well, I think it's Deborah's department, really, because she's been the greatest advocate of acupressure as far as I can see. But I teach it all the time. I think it's fantastic. It's empowering. I don't see any particular problems with it as long as you know your patient and you have excluded any particular contraindications. But over to you.
Yeah, I give it out as specific homework, so you're actually giving people specific points to do in a specific regime. So it might be 3 times a week, getting the partners to massage their shoulders and go down into their lower backs for 5 or 10 minutes as a labour prep treatment. It's hopefully clearly in the booklet that that there are some points that you can use to step up just before a medical induction, and then you use them every 2 hours, over 2 or 3 days. And there's some trials going on at the moment where they're using that as part of VBAC clinics and maybe as part of a gestational diabetes clinic. So the idea that when you've got an induction date looming for whatever reason, you could step up and design a specific acupressure program for those women as well. I don't think we can stop people going away and thinking that they want to stimulate labour and that they will do all of these points every 2 hours when they're 39 weeks. However, hopefully if they've come to see you, they've got a good reason, you've talked about that with them, and they've got a good rationale about why it's the most beneficial, the highest chance that they're going to have this most efficient, beneficial labour that they find really empowering is if they give their body the best chance to wait the longest.
Thank you. And I don't think we need to go into more detail. I think most people think it's okay to give the women homework to prepare themselves, right? There's no objections to that, and we'll move on otherwise. Okay. So the question that was asked is, what should you look for and ask when considering an induction? Actually, and I'm gonna take that out because we kind of said we don't do induction. So what are your thoughts on inductions for? Now, this question was asked at the very beginning. So basically, we want the acupuncture perspective. So if somebody's coming to you and now you're thinking, my job is to support this woman, soften, prepare, do the birth preparation. We're not trying to force contractions or labor. Are there any red flags or things that we need to be thinking about if a woman comes in and she's carrying twins, or she has a breech baby, she's over 40, she's planning to do a VBAC, or any other complication like gestational diabetes or high blood pressure? Now, I know you guys all cover this in your course, and we only have so much time, so we can't go into detail, but is there any concerns by doing pre-birth or cervical ripening if anybody's coming in, either twins, breech, VBAC, for example? Do you have any
well, very quickly, twins, you want to hold them in as long as you can. So it's the opposite of cervical ripening. You want to do 20 and everything you can to raise her chi and keep her in the oven as long as possible. Gestational diabetes, I think we talked about. I don't think it hurts them any to try and keep in touch with them and do, you wouldn't exactly say cervical ripening treatments, but you would say labor preparation treatments at least a week or 2 in advance of when she's scheduled to be induced, if that's what's happening, because the baby will be bigger than her body would really want it to be. And then VBAC, I think we can really, really help people by helping the rest of their body to be as ready as possible, given that her uterus has some built-in chi stagnation in it. And similarly, advanced maternal age, right? She's in her chi and, well, her yin and blood aren't as much as they could be, so it'll be on the nourishing, dilating side. I know my liver's a little crankier than it was when I was younger than 40. Hypertension, I'm not going to take on hypertension in a labor prep class. It's a whole big subject.
And Deborah Betts' class online does go into strategies for hypertension. You know what? Because I will forget this. I have to share a quick story in here, because this is I'm treating she's already had her baby, healthy baby. So she's at this time around 35 weeks pregnant, and she's developed some hypertension. And what's really neat is she has a pacemaker. So she had to have heart surgery as a child, and she has a pacemaker, and she's developed high blood pressure, and she's wearing a monitor. And so she comes into my clinic with the monitor. So I'm, doing my intake, I'm treating. And Deborah, I always remember some of the empirical ideas for the hypertension. I remember like the large intestine 11, liver 3, stomach 36 idea. And I'm needling, and we see the monitor, and as I needle, we're seeing the blood pressure go from like 92 to 60. And I played with the needle. So I played with stomach 36, large intestine 11, liver, and I played to see which one had the most profound effect. And it was incredible because she was watching. She was sitting there, and I'd needle it, and then it would go way down and then slowly creep up, but never back to 90, creep back to 70-something. And then I would needle it, it would drop down to 60-something, slowly, and stay at 70. And we did that on a weekly basis and kept her off of any needing induction or anything because her blood pressure was under control. But I thought I would share that with you. It's just a clinical anecdotal story that here I was needling somebody, and we could actually, usually they come in with gestational hypertension. We're not measuring in the clinic on a regular basis, and we send them back hoping everything's okay. But I was actually in the clinic needling, and as I needled, her monitor was there, and we could see her pulse rate drop, which is quite nice. So, anyways, I digress, but I just want to say thank you for that.
No, but it's like that at the hospital needling with the contraction monitor on. You wouldn't recommend that your patient have continuous fetal monitoring, but since it's there, it's really nice to see what your needles are doing.
So you
Absolutely,
see this in the
all
hospital?
The time. I've bled the ear point and seen the baby's heart rate go down. You tap on UB67 and you see the baby heart rate make a little acceleration. You needle LI4 and you see the contractions get bigger. You needle spleen 6 and you see them get smoother. It's really fun. I have a whole, probably OCD, much more elaborate than it needs to, but the contractions are really a pulse. You see the yin-yang qi blood in the shape of how the qi is moving through the uterus. It's fascinating.
Great, thank you. It's just nice to see that, and I remember one of your lectures you're sharing the monitor, and it's just nice. It's like another way of taking pulse in a sense, or a different way of looking at pulse. Here's another question for you. So just because it's acupuncture leading up to labor, in labor, so just some strategies. Can
Lorne,
you talk
sorry to interrupt. Yes. Coming back to, just before we move on, that question about, the breech and the VBACs and the gestational diabetes and the high blood pressure, I think what we're talking about here is really Sarah's lecture about the idea that as practitioners in this area, you need to have a good grasp of the red flags, so that if you're working on that level, then you will be able to design treatments that are actually going to be useful. So just coming back to your high blood pressure story, that's really great. But if there's actually something happening with the baby in the uterus to do with the other preeclamptic signs, then just the blood pressure by itself is not enough. So it's this idea of understanding what you're working with and what the Western medical people, why they think things are dangerous and why they're concerned, that allows you to design your treatment around what you want to do. And does that make sense? So just as we...
It's a good point that you bring up. Yeah. And it's a good point that, like, we are not the primary birth attendant. We're not birth attendants. So they're always seeing their midwife or their physician. And this woman, it was great because she had such a team. Because she had a pacemaker and she has this known heart condition, she was monitored very closely for the, the protein in the urine and the preeclampsia, all those things. And we have our little checklist, if they start to get the edema, do they get headaches, are they having this? We look for those signs. So again, because I remember, Deborah, in your lecture, so just because we're all about safety and positive outcomes, one of the concerns that the midwives and what you brought up and what you're alluding to here is, if somebody has high blood pressure and you start to treat the high blood pressure and you make that symptom go away, are you covering up a bigger issue? So I think that's what you're bringing out here, is they need to be monitored and make sure that we don't hide an important system or important symptom here that let us know that the baby or mom are in jeopardy or danger, correct?
And just for any of those conditions that we're talking about, like the VBACs, there are some times when a vaginal birth is not going to be a good idea after a cesarean section, and that's a medical decision. And we did recently have a woman here in New Zealand where the baby died and she lost her uterus. And she went against medical advice because she thought it would be safe. So we just have to be very careful that we know that why these people are concerned about some conditions, and we're working with the medical team.
Good, thank you. During labor, so needling during labor, you're trying to help with pain and maybe keep the labor going. She wants to move around, active labor. Any advice on what you're doing with women in labor? Is it more acupressure? Are you using pressed needles? Are you taping them down? All three of you have experience.
I'll be really quick. It's how I got into acupuncture back in the 1980s, I'm afraid.
Some pointers on this?
And quickly realised that for us in the hospital, the best way was to use ear acupuncture with electro acupuncture leads attached, so that the woman could control the stimulus herself, a bit like a TENS machine, and that worked incredibly well. And to see a woman with a good acupuncture birth analgesia is just a wonderful thing. It was so calm and in a lovely space. Have to say that then you have the availability issue, so we switched to using acupressure as an alternative, and that was also very successful. I want to very quickly, because I was muted just now, just say about those previous conditions, sorry. I just think as professionals it's really important to understand the implications of all of those situations, because we have a therapeutic relationship with these women and they want to discuss things with you. And so please, just to be well informed about the consequences when things are red flag type situations like VBAC and breech births, etc. Okay, sorry, just go back to labour now.
Okay, thank you, Sarah. So I'm going to go on because we're running out of time, so I want to, rather than everybody addressing each point, there's a question about using the contraindicated points. Now, first I'm going to mention at the Integrated Fertility Symposium in Vancouver, we have a panel, and Deborah Betts is on it, Sharon Weizenbaum, and I can't remember who else, and the lecture topic is using forbidden points and blood-moving herbs during the luteal phase in early pregnancy. So we're going to get more into that, whether they should be called contraindicated points or cautionary points. But in this case specifically, what do you think about using the contraindicated pregnancy points after 38 weeks with a different aim than inducement? Example, spleen 3 to tonify weak spleen chi, or gallbladder 21 for tension and high blood pressure. Claudia responded, Monica, in case we don't get to it, which we're doing now, this is really important for any given treatment principle. There are other ways to accomplish it, and you just don't want to be the practitioner who charted forbidden points for that unlucky patient who went into labor 3 hours after treatment. Claudia, for you and the others is, but if the woman's already at term 38 weeks and you're using points like gallbladder 21 or spleen 6 because the pattern warrants it, and they do go into labor without you trying to induce, is there an issue here? Because women go into labor at 38 weeks without ever having acupuncture. So are we concerned at 38 weeks?
Yeah, no, sorry. I missed that piece a little bit. This is just such a hot button issue for me that I jumped on it and charged in right. I do think it's critically important to avoid those points before 38 weeks. At 38 weeks, I think it's much less of a big deal. But the more research we do, the more we see that they've actually, ACOG in the U.S. has reorganized its terminology, and 38 weeks is now early term. It's still not optimal. So you're not trying to send her right into labor. That said, I'm completely less stressed about it. I guess I missed that piece of Monica's question. If it's 36 weeks, I really think it's important for the profession to avoid using those points, because the patient who does happen to lose her baby or have the baby born earlier than she wanted to, if the labor started right after your treatment, there's no basis for saying it wasn't the treatment.